What's up, guys? I wanted to record some bonus content because we had a question come in about maintenance programs, maintenance therapy, and coverage under the Medicare benefit policy manual. So my go-to resource is always CMS Chapter 15, scroll down to Section 220, look at maintenance therapy, look at the coverage guidelines. And then I also typically will look for local coverage policies from my Medicare MAC. And then I always like to touch on information about advanced beneficiary notice because I think you can glean some information from the content based on when to issue an ABN. So let's jump into those three resources real quick. Let's take a look at it and let's kind of build a foundation for how we can make decisions about maintenance therapy. So the first thing we're going to start with is CMS Chapter 15. You're going to scroll down to Section 220. You're going to scroll down to the coverage guidelines. And we're going to look at Section 220.2, reasonable and necessary outpatient therapy. We're going to scroll down specifically to the section about maintenance. I'm going to tell you, maintenance has always been covered. I remember 20 plus years ago looking at this document, being shocked at the idea that maintenance is a covered benefit under the Medicare policy, because we always hear in the clinic, you have to show progress, Medicare won't pay forever. We hear all of these things, but then you have to contrast that against the information that came out during the JIMO settlement, information that comes out related to Medicare does not require the patient to show improvement. Therapy could be a covered benefit to slow the deterioration of a condition. So we can see here, maintenance, establishing a maintenance program, generally a covered service. The delivery of the maintenance program is really where we're gonna focus today. And so a maintenance program can be generally, excuse me, let me say that again, because the way they word this is so confusing. Quote, a maintenance program can generally be performed by the beneficiary alone or with the assistance of a family member, caregiver, or unskilled personnel. In such situations, coverage is not provided. Why they have to say it in that way makes no sense to me. However, skilled therapy services are covered when an individualized assessment of a patient's clinical condition demonstrates that the specialized judgment, knowledge, and skills of a qualified therapist are necessary for the performance of safe and effective services under a maintenance program. Okay, so let's take a look at some examples. So they have example number one. Patient with Parkinson's is nearing the end of a rehabilitative therapy program, requires services of a therapist in the last week or weeks of treatment to determine what type of exercises will contribute to the most to maintain function to prevent or slow further deterioration in the patient's present functional level. In such situations, the establishment of a maintenance program may be appropriate. The capacity and tolerance of the patient by a qualified therapist, the instruction of the patient or family member in carrying out the program, and such reassessments or reevaluations as may be required may constitute, not will, may constitute covered therapy because of the need for a skilled therapist. May is an important word in this scenario because that indicates that they're not guaranteeing coverage. And when we look at this, we have to do a risk analysis. We have to understand what is the risk we're assuming as the therapist providing the therapy services. What if I determine this patient needs 7 covered visits under a maintenance program, and Medicare determines, no, we actually will pay for 3. Well, 4 of those services are not going to get paid. I am assuming the financial risk and responsibility of those 4 visits. I cannot bill the patient if I didn't provide an advanced beneficiary notice indicating to the patient that I didn't believe those services were medically necessary. I didn't do that because I did believe the services were medically necessary. Now, it doesn't mean that I did anything wrong. I didn't do anything illegal. I wasn't trying to commit fraud. I genuinely believed the patient needed 7. The Medicare reviewer believed the patient needed 3. Now I have the choice. Obviously, I have to refund the money, but I also can fight the decision. But now I have to assume the cost and the responsibility and the stress of fighting that decision. for, the reimbursement of 4 visits. I'm probably going to lose more money in the fight process than I would ever recover from getting those visits approved. Scenario number 2, right? A patient with MS needs a maintenance program to slow or prevent deterioration in communication ability caused by the medical condition. I like this example. I think this goes to the heart of the problem. Therapy services from a qualified speech language pathologist may be covered to establish the maintenance program, even though the patient's current medical condition does not yet justify the need for individualized skilled therapy sessions. So the patient is doing good enough that they don't need therapy, but they do need a maintenance program to be specifically prescribed for them. Evaluation, establishment of the program, training the family or support personnel may require the skills of a therapist and would be covered. Notice it's not delivering the service. It's not the intervention itself. It's evaluating, establishing the program, training the family or support personnel. And there are other examples within Medicare guidelines where they state if the patient doesn't have support personnel to train, if the patient is incapable of learning and understanding what needs to be done, continued therapy is not a covered benefit any longer. So that is a great example of what maintenance really is, establishing a maintenance program, educating about the maintenance program, and so on. Number 3, where there is an unhealed, unstable fracture that requires regular exercise to maintain function until the fracture heals. Until the fracture heals is an important element within this, because they're not saying the fracture is never going to heal. The skills of a therapist may be needed to ensure that the fractured extremity is maintained in proper position and alignment during the range of motion exercises. In this case, since the skills of a therapist may be required to safely carry out the maintenance program, given the patient's particular medical complication, therapy services would be covered. So this is another really great example where they're saying, okay, we're expecting this fracture to heal during the interim where it's unhealed, unstable. I can't adequately train a non-licensed person to mobilize the joint, provide the passive range of motion, do the things that we need done. So the therapist needs to do it. But I would bet, based on my interpretation of other guidelines, if this fracture was never going to heal, if it was never going to improve, once I determined that the patient could not do self-mobilization, self-passive range of motion, and doesn't have assistance to do it, coverage is no longer available. It would have to be a self-pay service until the patient had an episode where they declined, where there was a complication, where there was a new injury or an exacerbation of the existing condition. Now, in this case, I would argue that I can't think of the word, but occasional assessment would be appropriate. So maybe this person, once you determine that the fracture is never going to heal and they're not going to have surgery, maybe every 6 weeks you come in, you assess, you see how they're doing. Did they decline? Are they maintaining? What's going on? If they declined or had an exacerbation, you can resume rehabilitative therapy for a period. But we could not just continue indefinitely providing the service. That really would become palliative in nature. Finally, we've got another one about MS. This is the last one I'll read. There's a couple more for you to check out. Patient with a long history of MS, difficulty transferring in and out of a wheelchair, maintaining range of motion of the lower extremity due to increased spasticity and muscle tone since the most recent exacerbation. The beneficiary is unable to walk, but is independent with the use of a wheelchair. Beneficiary needs to be able to safely transfer in and out of the wheelchair by herself or with the assistance of a family member or caregiver. The individualized assessment of a physical therapist, and given the patient's overall medical and physical condition, the skills of a therapist are required. Notice this is the first time we see the word are required to instruct the patient or caregiver on proper techniques of wheelchair transfer and lower extremity stretches due to special medical complications from the progression of MS. When the therapist determines that the patient can carry out the transfers and stretching activities safely and effectively, either alone or with the assistance of a caregiver, the skills of a therapist are no longer necessary. I would add to that, or when the therapist determines that the patient is not going to be capable of doing it and does not have assistance from a caregiver or family member. In that situation as well, continued therapy is no longer a covered benefit. So there are multiple situations here, examples that you can really pull from to help you decide when is therapy covered, when is it not, whether it be maintenance or rehabilitative. Let's take a look at another document. Let's look at this right here, L34049. So this is outpatient physical and occupational therapy services. You can find this in the cms.gov database. I believe I'm going to do a Control F, CGS. Hang on. Why are you not showing up? There we go. CGS. Yeah, so this is a source of information from CGS administrators. That is my particular Medicare MAC. And what we want to do, again, I'm going to search the document. So I hit Control F, maintenance, and you can see here, if I scroll up just a little bit, we've got definitions. The definitions of a maintenance program means a program established by a therapist that consists of activities and or mechanisms that will assist a beneficiary in maximizing or maintaining the progress he or she has made during therapy. So, or to prevent and slow the deterioration due to the disease. Medical necessity information in here. Let's look at the next cited reference. So in the case of maintenance therapy, if I scroll up a little bit, so we're in the medical necessity section. Treatment by a therapist is necessary to maintain, prevent, or slow deterioration. This slow the deterioration is what really tricks therapists into thinking that they can just continue to do what they've been doing infinitely. You can't. You just can't. Slow deterioration of a patient's functional status. Services cannot safely be carried out by the beneficiary or family member, caregiver, unskilled personnel. A therapy plan of care is developed either by the physician, non-physician practitioner, physical therapist, occupational therapist, speech language pathologist. If the goal of the plan of care is to improve function, the documentation must establish that the patient needs the unique skills of a therapist to improve functioning. If the goal of the plan of care is to maintain, prevent, or slow the deterioration of functional status, function, or prevent deterioration, the documentation must establish that the patient needs the skills of a therapist to maintain, prevent, or slow further deterioration of functional status. All services provided are to be specific and effective treatment for the patient's condition according to accepted standards of medical practice, and the amount, frequency, and duration of services must be reasonable. Reasonable is an important word in this paragraph because what is reasonable? How do you define reasonable? Reasonable for, what kind of person? Reasonable based on standards of care. And so you're comparing your plan of care to 1,000 other plans of care established by other therapists who may or may not be as diligent as you, as impactful as you, as compassionate as you. Think about the typical therapist in a typical outpatient hospital setting. Think about the therapist in a skilled nursing setting. Think about the therapist that has 20, 30, 40 other patients that they're managing. They have a waiting list of 15 or 15 evals that need to be on the schedule for this week. Those therapists are not doing what you're doing, but they are establishing and contributing to the standard of care and what is determined to be reasonable. So this is how you go about establishing the differences between what you define as maintenance therapy. You can see here, this is going to be very similar to what we saw in CMS Chapter 15. But this is where you create your own internal policies that help guide your decision-making process. The last document that I wanted to show you, and this is by no means the last document that exists, is this one. Let me see where we are. So we're on page 7. This is related to the Medicare Advanced Beneficiary Notice. Let's jump back down there. Talks about when you issue an ABN. For example, we're going to look at the reduction. So reductions happen when a component of care decreases, for example, frequency of a service or duration. Don't issue a notice every time there's a care reduction. If a reduction happens and the patient wants to continue getting care that is no longer considered medically necessary and reasonable, you must issue the notice before the patient gets the non-covered service, right? So this is the patient who potentially was getting therapy 3 days a week. You want to transition to 2 or 1 day a week, but they want to continue with 3, or you prescribe 2 and they want 5, or they're on a home health plan of care and home health is only prescribed 2 and the patient's family wants them to get 5. You're going to come in as an outpatient therapist providing the additional 3. Those are examples of cash pay services that are available to Medicare beneficiaries, as long as you issue the advanced beneficiary notice to adequately inform that patient of the cost of the therapy services and the reason those therapy services are not covered by Medicare. Termination. So this is back to what is maintenance that's covered by Medicare versus what is maintenance that's not covered by Medicare. Termination stops all or certain items of service. If you terminate services and the patient wants to continue getting care no longer considered medically necessary or reasonable, you must issue the notice before the patient gets the non-covered service to transfer financial liability. And this is what I want to wrap up with. I'm going to stop sharing screen for a minute. There's 2 scenarios, therapist A and therapist B. Therapist A evaluates a patient with a specific set of, impairments and complexities and all this stuff. And that therapist A determines this patient needs 10 visits. They need the evaluation and initiation of care. They need 5 therapy sessions to achieve improvement, educate, move toward these functional goals. So that puts us at 6. And then they're going to do 4 more to establish, initiate, train on what's going to be the continuity program, a non-covered maintenance program. Okay, you evaluate the same exact patient. You make the determination. You see far more complexities. You see far more nuances to this patient's case, because maybe patient A was a new grad with very little experience, and you're a veteran with 25 years experience and more letters after your name than I can mention. And so you determine, no, this patient can't only get 10 visits, they need 36 visits. Or you initiate with 36 visits, and then you determine this patient needs another 24 visits, right? So we're at like 60 visits. Whatever you do, you make your determination, the other therapist makes their determination. You believe, based on your clinical knowledge, that everything you do is reasonable and medically necessary. But again, the Medicare reviewer comes along, selects both your caseload, the other therapist's caseload, does an audit on them. The other guy who did 10 visits, he gets paid, no problem. He's well within the guidelines of what's expected, even if it was less effective of care. Even if the patient returns to therapy 2 months later with a greater exacerbation and more problems, even if that patient was discharged, in your opinion, prematurely, that is a licensed therapist and you're a licensed therapist. They are entitled to their professional opinion and judgment. They get paid. Your charts come under review. The reviewer says, this is way beyond what we would consider reasonable and necessary. The gains or slowing the deterioration is nowhere near what we would expect to pay for this. We'll pay for the first 12. In fact, we'll pay for the first 18, but the remaining 42 visits, we are not paying for those. We are taking back the money on those. And because we see such a gross overutilization of services based on comparison to the national standards or locally adjusted norms, we want to see more medical records. We want to take a look at more charts. And so now you are on the financial hook for all of that. You didn't do anything wrong. You did not do anything wrong, but the reality is your understanding of the Medicare guideline is different than the reviewer's understanding. And I go back to the same situation. If you would have issued an advanced beneficiary notice because you truly believed those services were no longer medically necessary based on Medicare guidelines, not based on what's best for the patient, but based on Medicare guidelines. You issue the ABN, the patient pays you out of pocket. The patient chooses option number 1 on the ABN. You submit the claims to Medicare. Medicare issues the letter allowing or informing the patient that they could dispute the non-coverage. Let's pretend the patient disputes it. Let's pretend, I've never heard of this happening, but it could. The patient wins the dispute. What's the worst that happens? Medicare comes back, they pay you for the services, you refund the patient the money, you are no worse for wear. But that never happens. What happens is the therapist digs in, they refuse to acknowledge what Medicare coverage policies actually are. They continue to deliver service. A year later, 2 years later, 3 years later, they get selected for a post-payment review. All of a sudden they realize, wow, this, even with the best documentation, this does not justify reasonable and medically necessary services. That's where we have to wrap up. So how do you determine what's appropriate? You got to use your best clinical judgment. You got to go to those resources. You got to understand what Medicare has published and use that to help create a framework to make a decision. And then you have to look at that in the context of the big picture. What is the standard of care? What is your standard of care? What is your risk tolerance for being able to pay back thousands, tens of thousands, hundreds of thousands of dollars versus providing the Medicare beneficiary with the opportunity to assume some of the risk in exchange for continued services? I think these are all more than reasonable. Go out there. I'm looking for a way to end this. Go out there, create your policies, have a framework to make your decisions, and I wish you the best.